It is currently managed by QCore. Together with the experts we partner with, our goal is to get primary care practices connected to a broad array of technical assistance as they work towards the patient-centered primary care home or medical home model. We work to serve practices at all stages of transformation and to build capacity and create alignment to support ongoing transformation and quality improvement in Oregon. We encourage you to visit our website, www.peacepci.org, to access resources, including previous webinars, and this one we are recording, and this will be posted on our webinar with the slides. And then you can also sign up for our email list on the website, which is how we'll announce additional web-based and in-person training opportunities, as well as future institute programs. As I said, we are supporting practices and attaining the PEACE-PCH model of care. Here's a little bit more about that model. And without further ado, I'm going to turn things over into the capable hands of our expert presenters. And our first person I'm going to turn it over to is Ms. Colleen Ruland, who is the director of the Oregon Pediatric Improvement Partnership, and she will introduce herself and our other presenter.
Hi, thanks, Rebecca, and thanks for all of you that have joined on this Thursday morning. I'm excited to share the detailed work that we've been doing in 3 different communities in Marion, Polk, and Yamhill, and hope that I can provide this quite varied audience different sets of tools that might be helpful in your own world. And then I have the honor of having Suzanne Dinsmore on the call with me. She is a pediatrician at Childhood Health Associates of Salem, which is a primary care practice in Salem that is piloting a number of the tools that I am going to be sharing today. So given that some of the audience are primary care practices who are patient-centered primary care homes, we thought it would be invaluable to have a patient-centered primary care home share their first-hand experience with this work and the key learnings that they're gathering. Okay. There we go. So in terms of my objectives for the presentation, they are to give you an overview of the community level asset mapping that we've conducted. That's been really focused on you do developmental screening, but then how do you identify the follow-up resources in the community that can help address the risks that you identify in developmental screening? And then once you identify those resources, what are the methods? How do you refer? How do you make sure that you hear back? And how do you ensure care coordination? So as Rebecca mentioned, one of the kind of tensions I had in preparing for this presentation is that we have a quite varied audience today. So we have primary care practices who are on the call. We have early learning hubs who are on the call, public health, early intervention, CCOs, and then a bunch of other early learning system providers. So I am going to try to go for breadth and a lot of kind of overview so that I'm giving each one of you something that's useful, knowing that where I'll kind of focus a little bit more of the depth is on some of the work that's happening in primary care, given the audience that there's a lot of primary care providers on here. But I'm happy to follow up with anybody afterwards, given that I know each one of you have kind of a different lens of how you're looking at this topic area, and feel free to email me with questions, and I'd be happy to share further. So how I'm going to achieve those objectives is I thought I would just level set and make sure that we're kind of all clear on the recommendations around developmental screening in primary care and some of the great momentum that our state has created around screening, which now affords us the opportunity to think about the point of screening, which is follow-up. And so from that angle, I'm going to then share how, as an organization, in our efforts to do community and population-based improvement around follow-up, how we approach that. So we approached it through getting data, both qualitative and quantitative. We developed a community asset map, and then we are now piloting tools that are really meant to go from increasing the proportion of children who are identified at risk on developmental screening actually receiving follow-up. And then we'll end the webinar with Dr. Dinsmore's perspective as a primary care practice. All right, so just to level set, developmental screening, the recommendation originally came out in 2001, so we're approaching 16 years of the recommendation, and it has now been part of Bright Futures, which are national recommendations across all types of providers that provide primary care to children. And the recommendations have 2 parts. One is that there's supposed to be standardized developmental surveillance across the 5 domains of a child's development. And if in that surveillance you identify a delay or a concern, or the parent notes a concern, then you're supposed to implement standardized developmental screening tools. So examples of standardized screening tools are the Ages and Stages questionnaire and the parent's evaluation of developmental status, for example. And then in addition, primary care practices are supposed to implement these standardized screening tools 3 times in the first 3 years of life. Given the evidence that shows that these surveillance models, while they're helpful, they often miss most children that we need to be identifying early. And so the screening periodicity in primary care is that it should happen at the 9-month, the 18-month, and the 30-month visit. Given some practices don't provide the 30-month visit, the recommendations in the past have noted that then you could do it at the 24-month visit. So what's great about our state is that we have momentum around this concept of developmental screening in primary care, and we also have momentum around concept of developmental screening outside of primary care, so within home visiting and within child care centers. Some of that momentum is caused by the Coordinated Care Organization Incentive Metric, which measures whether providers submit claims in the context of primary care that align with standardized developmental screening tools. It's in the 2017 standards, it's a must-pass requirement that practices who attest to patients in our primary care homes have to do developmental screening. And then within early learning hubs, there's an alignment of the primary care-based CCO developmental screening measure. So what's great is we have this energy and momentum around developmental screening. But for OPIP, what we wanted to focus on, we've been involved in a number of those efforts around screening. But the point of developmental screening isn't to screen. The point of developmental screening is to make sure that children that we're identifying at risk for delays are receiving promotion and also receiving follow-up services that understand better those delays and how we can serve them in a way that's the best match for that child and for that family. So for the rest of the presentation, when I talk about children identified at risk, so who that population is, what I'm talking about are those kids who are identified on the developmental screening tool as being at risk for developmental, behavioral, and social delays. The work that I'm spotlighting is summarizing work across Marion, Polk, and Yamhill County. And in these areas, a majority, over 90% of the practices who are doing developmental screening are using the Ages and Stages questionnaire. And some of the community-based screening tools, the majority of them are using the Ages and Stages questionnaire. So for the rest of the presentation, my frame is going to be kiddos that are identified at risk on the Ages and Stages questionnaire, which would mean that there are 5 domains on the Ages and Stages questionnaire. And it would mean a kid has showed up in the black, which means there are 2 standard deviations from normal in 1 domain, or they are in the gray, which would mean there are 1.5 standard deviations on 2 domains on the Ages and Stages questionnaire. Okay, so another great thing about Oregon is not only do we have this focus on developmental screening, but we also have these amazing systems that are trying to coordinate and enhance a focus on better care. And in particular, when we're thinking about young children, we have these systems that are focused on children 0 to 5. So the great part that we have about Oregon is that we have these things called coordinated care organizations, which are meant to coordinate care better. We have these early learning hubs, which are meant to kind of provide a hub of services that serve children under 5. And then we have early intervention. So the opportunity that we have with this project is to actually go across those silos and think about, as you identify a child on the left silo, so as you identify a child on developmental screening, how do we feed them in better into these other silos that we have the opportunity to connect better in this state? And so that's really where OPIP's work has been and where I'm going to be spotlighting our projects. So as we thought about, like, how would you cut across those silos, we really thought that there were kind of 2 big things that needed to be done. One is you need to engage the stakeholders in the community, because how you get across those silos and how you access those services and what services exist depends on the community that is there, and depends on the resources, the referral flows in the community. So the first part of our work has really been around engaging stakeholders, looking at data, so we can have a data-informed conversation about how many kids we're talking about, and a data-informed conversation about capacity. And then just as importantly, thinking about, so while we can identify these places, these nodes that we could refer children, how do we refer them to those services, and which kids should go, and how would we hear back? So that's the first chunk of work that we have done and that I'll be sharing. And then using that information tailored to the community and tailored to the population, we identified 3 priority areas that we were going to focus our quality improvement efforts. So the first is within primary care, how they could enhance the follow-up that they're providing. The second was with early intervention, how they could enhance the coordination and communication. And then the third has been identifying early learning services that providers hadn't traditionally referred based on the developmental screening results. But how could we develop a better pathway for them to get into those early learning services, given that they're identifying these risks? So I'm going to go through that first part, the stakeholder engagement and the community asset mapping part first, which will be really relevant to the Early Learning Hub, CCO, early intervention folks on the call. And then I'm going to go deep on the kind of pilot methods that we've done around trying to improve the number of children identified, particularly in primary care, given in these communities that still where a majority of children are screened, and some of the learnings we gathered from there, which is going to be extremely relevant for those of you that are primary care practices on the call, and also relevant for those of you who are early learning system providers, to give you kind of more of a sense of how do you actually create this dot connection and these referral pathways to you from primary care. So when I talk about stakeholder engagement, we did about 70 interviews across Marion, Polk, and Yamhill to really understand what is happening now around developmental screening and follow-up. And I thought I'd just give you all, given that we have such a varied audience, kind of a bullet list of all the different types of stakeholders that we engaged within health, within public health, within early learning hubs, and with early intervention, and within child care. And when we did these interviews, what we focused on is for those doing screening, what did they do for follow-up? And for those that provide follow-up services, what services do you have? How do you catch people? And what's your process of communicating back? One of the things OPIP is really committed to is making sure that our work is patient-centered and patient-informed. So one of the things we did is we recruited and paid 3 parent advisors to also provide their perspective. So they each have had children who have gone through developmental screening and been identified and had to receive services. And what was their experience? And as we're thinking about trying to improve the promotion and follow-up that children get, as a parent, what would be their advice? So once we collected all this robust data in terms of interviews and data, what we needed to do was then make sure that the community kind of identified and digested the information that we had about what the current state was, and then that the community coalesced around what should be our priorities, not only in terms of where we focus, but what pathways we focus on. Because I will show you a map, we could have focused on a number of pathways, and what we had to do was prioritize which ones. And so the process that we used to prioritize which ones was we let the community itself prioritize which ones, using and being informed by the stakeholder engagement and the quantitative data. And here is where the Early Learning Hub folks, this is where you have a great opportunity. Because when I showed the previous stakeholders that we engaged, I'm sure you saw yourself in there, and I'm sure you saw a number of the partners that you were working fantastically with to pull together. So we were extremely lucky in that we had very strong hubs in these communities. We had the Yamhill Early Learning Hub and the Marion and Polk Early Learning Hub, who had already done a fantastic job of convening the early learning system stakeholders. So for this project, what we did is we really leveraged that table, but enhanced it for this one refined focus area. So we pulled in primary care. We pulled in a lower level, like a level below CCO administrator in some of these conversations, so that we could talk very specifically about a very specific population, children under 3, identified at risk on developmental screening. So it's one place where it's just been a wonderful area of synergy with the early learning hubs. The other thing that we leverage from the early learning hubs is, again, we wanted parent feedback. I will be showing you some tools that we developed that are directed to the parent. And we really wanted to make sure parents gave us their insight. And here again is where we were really lucky to be able to leverage off some of the great work that the hubs have done. So in Marion and Polk, for example, they have a wonderful parent advisory group. And when we were developing parent education materials, that parent advisory group gave us great insight and input. can imagine, the stakeholder interviews, the reason I show this slide as detailed as it is our whole point was to get into the weeds, because what we wanted to know is what exists now, how do we improve it, and where do we focus? And so this is the culmination of all those stakeholder interviews. What are the services that exist, so the gray boxes? What are the follow-up steps that exist if a kiddo is found eligible or not? And then just as importantly, what are the connectors? So in this really complicated visual, the important thing to take note of is that solid lines mean things that are consistently happening in a standardized way. There's a routine process. And you'll see that there's a line in to referral processes, and there's a line out, meaning communication and feedback. Dotted lines mean that there is not a standardized process. Or if there's no line, that means there's not a standardized process for getting there. So what the point of this project was is to take arrows that are dotted and make them solid. Create a standardized process, create a standardized way of referral in and referral out, and to prioritize which pathways we should be identifying for children. And how do we make it simple, doable, and refined so that people can implement it in a meaningful way? For those of you on the call, a number of you noted that you really wanted to hear and learn about asset mapping. So I showed you kind of like how we summarize the stakeholder interviews, but particularly for the Early Learning Hub folks and the CCOs, I wanted to let you know that we have put a bare bones template of this visual that has been extremely helpful in our community engagement processes in case you wanted to take it and use it yourself. The second thing that we did is we gathered that qualitative information through the stakeholder interviews. But again, we were really committed to quantitative data, so we could really start to be talking about capacity and talk about need. And so the data that we looked at in these communities was, one, the CCO level data about developmental screening. So overall, what were the rates? But then what were the rates by practices? What were the rates by specific types of children? And where were there opportunities and gaps? The second is that we looked at the pilot practice level data. So within the 3 primary care practices that we've been working with in these 3 communities, we had them pull data from their electronic medical record about, okay, so of the screens you're doing, how many children are identified at risk? And then what do you document now around your follow-up steps? So again, we can kind of start to see where are there opportunities. Are most children getting follow-up or most children not? How do we make sure that we kind of are data informed about what children aren't getting referred? And then because early intervention is one of the primary pathways that a child should be referred to, it is not the only, we wanted to really look at that. So of those kids that get referred, how many get evaluated? And of those that get evaluated, how many are found eligible? And are there disparities by insurance type or race ethnicity? So I wish I could spend the entire hour on just that data because it's extremely rich. And in our community level conversations, it was the first time that the data across these 3 different siloed sources was ever presented to kind of give a full picture of where children are falling out. When we're talking about the goal of from screening to services, the data has been illuminating about where children are falling out and informing our priorities. But given I'm a little crunched on time, I'm just going to highlight a couple of data sources that we found. So again, developmental screening in these communities has increased. So there's been an increase in screening. It is important to note that while developmental screening has increased and both of these CCOs have met their incentive benchmark every year, it still remains that a majority, 50% of kiddos, are not screened. So one of the kind of myths was they were like, well, we're doing well in developmental screening because the well was that they were meeting the incentive benchmark for the CCO. But when we're thinking about this kind of population of children that should be getting follow-up, one could debate whether half of kids getting screened means we're doing well. So I'm really excited to see that the benchmark has increased to up to 61.5, but again, that would still mean 2 out of 5 kids aren't screened that should be screened. So one of the things, again, that we wanted to look at was like the follow-up. So the visual that I'm showing you here for the primary care practices, this will look very familiar because this is the Bright Futures AAP recommendation for follow-up. And so in the Bright Futures recommendation for follow-up, it says that children who are identified at risk, who have a screening result that's positive, should receive a referral to a developmental medical evaluation and to early intervention. So one of the things we wanted to look at was, how does that look? You know, like, so if one of the pathways is that all those children identified at risk, and I will talk later about whether I think that's the right criteria in Oregon, should be referred to DBPs and to early intervention. So one of the things that we did in this community is we actually looked. So on the left is the proportion of children screened. So in this community, for example, in Marion and Polk, in the time period that we were presenting the baseline data, the screening rate has gone up 79%. And again, if Bright Futures recommendations were implemented and appropriate in these communities, it would be that of those children screened that were identified at risk, and in the primary care practices, it looks like that's about 20 to 28% of kids. If you rotely follow the Bright Futures recommendations, that would mean that 20% of those kids should be referred to early intervention. And so what we wanted to look at is how many children in that same time period in the same community ended up getting services, and was the increase on par with the dramatic increase of developmental screening. And what we found is, while there has been an increase, there's been a 10% increase in Marion and an 11% increase in Polk, the magnitude of the increase is not in line with the magnitude of increase in developmental screening. So we wanted to understand that a little bit better. So that's why that primary care data was really valuable. And again, in looking at the 3 primary care practices, what we found is that 60 to 70% of children identified at risk on those developmental screening tools were not referred to early intervention. So if you think about like where we're losing kids on the developmental screening pathway, one is we still have kids not screened. 2, of those who are screened and identified at risk, they may not be getting follow-up. Then third, we wanted to look at, okay, well, of those kids who are screened and referred, which is the minority now, what happens with them? And what we found is that of those kids screened and referred, 61% were able to be evaluated, which would mean 39% are not. And the reasons that they weren't able to be evaluated is parent delay, inability to contact the family, and family declining the evaluation. And the reason I'm going to note those is later on you're going to hear about how we're trying to kind of reduce that 39%. Then of those children able to be evaluated, 62% were found eligible for services, meaning that 38% were found ineligible. So again, when we're thinking about this kind of pathway from screening to services, it's another place where children are dropping out. So we really wanted to understand this better because, again, we wanted to develop tools and strategies that would try to reduce the number of children falling out. And when you talk to primary care practices, there still is confusion and lack of awareness about the difference for recommendations about when to refer to EI. So again, that Bright Futures recommendation says if a child's 1 in the black or 2 in the gray, refer to EI. There's still confusion that that's what the EI eligibility criteria is. And in reality, it is not the EI eligibility criteria, and EI does not use ages and stages domain level scores for EI eligibility. So providers are holding kids, not referring, because they have a perception, and I think the data actually confirms some of their perception, that many children that are referred aren't going to be eligible. So why would I refer them? I'm going to wait until it seems more necessary. The second is that there's parent pushback on referrals, and there's cultural variations on that. While the provider may think it's a good referral, the parent may not be ready for that. The third is providers will tell you, well, it depends. It's not just the screening tool. Some of those families, I know it's just due to a lack of exposure on the kinds of things that the ASQ asks. And so for them, they really want a decision tree that isn't just black and white, refer to EI developmental peds, but takes into account child and family factors. And then the last is they know that there are other resources that may benefit that child, but they don't know what they are in their community, and they don't know which kids to refer to. The other thing that we heard is that parents need support. The reason 39% of parents don't get in, there's a component of that is because the parent is not following through or doesn't understand why it's important. And when you look at kind of the support that we're giving families, I think there's an opportunity for improvement. One, in developmental promotion that could be given that day for that child, for that family. And 2 is education and support in navigating these different resources. Come on. Sorry, I'm having a advance. So taking all of that incredibly robust data that we gathered from qualitative information, quantitative information, we had that really detailed community asset map. What we needed to do is then refine it and make simple, standardized, implementable processes that could take this kind of rich information and make it applicable and feasible for us to address. So again, in their communities, we facilitated the community level conversation to decide which pathways, which areas we were going to focus on, because we couldn't focus on all those boxes in that complicated visual. And then what parts of those referral pathways, what lines were we going to try to make solid, and how would we make those lines from a service, from one service to another, how would we create that pathway of those services? So at a community level, what we identified as priorities was that within primary care, we were going to improve referral and parent support. With early intervention, improve communication and coordination. And within early learning, we were going to identify priority resources. So within primary care, again, in the Bright Futures recommendations, it's medical and therapy services, early intervention. So what you'll see is what we did is we instead created a medical decision tree that prioritized 6 services, but also identified how do you know which one is the best match for the child and the family, which takes into account the ASQ scores, but it also takes into account the family and the child contextual factors about which pathway is right for them. Okay, so this is a very detailed document, and Suzanne will talk about how it's been incredibly helpful because, again, what providers, primary care providers want is not just a black and white. It's the reason they're not referring a majority of children. What they want is something that is very refined to what are the ASQ scores, what are the child family factors, and what do I need to do? So let me walk you through this visual. So on the left side are the ASQ domain level scores across the 5 domains. And what you'll see is we have developmental promotion for every single kiddo. But then, depending upon their child's score, so not just this black and white, then there's guidance about when they should refer to early intervention, developmental pediatrician, and mental health. So a more refined pathway. On the right side of that medical decision tree is the linkage to the early learning system providers. But again, anchored to which kids should you refer and how would you refer. And so in these pilots, what we prioritized was referral to baby's first cocoon, referral to the centralized home visiting referrals that exist in these communities, and then referral to parenting classes, which would provide promotion services that would hopefully address some of the exposure issue that may be highlighting why that kiddo is identified at risk. So when I talk about promotion, one of the neat things that we kind of fed in that again was a focus within the Early Learning Hub was this kind of two-part promotion. One is global promotion, so using a tool like Vroom to give global promotion about how developmental promotion is something that is normal and that we need to do for our children. But then on the right was very specific to the domain that that child was identified at risk, the full one-page ASQ learning activities. So the primary care practices that we worked with had the ASQ table, which cut across the 5 domains, but they didn't know about the one-page developmental promotion that they could provide for that 1 domain or 2 domains or whatever domains that child was identified at risk. Then again, what we did is we created a referral pathway that was anchored to 3 groups. One was 2 or more children that were in the black. Again, most of the providers felt like a kiddo 1 in the black should not be referred to a developmental pediatrician. So what we wanted to do was kind of acknowledge that that's why they're holding them, but create a better pathway. So that's Group A, is 2 or more in the black. Group B and C align with the current kind of identification at risk, which is 1 in the black or 2 in the gray. And the difference between B and C is whether you refer to early intervention or not. And I'll talk through that in a little bit. So with Group A, this is the group of kiddos that have 2 or more domains in which there are 2 standard deviations from the norm. So again, one of the things we found is that these 3 practices still didn't have, one of them had been using the early intervention referral form. Another one didn't know what it was. And the third wasn't using it consistently and didn't know why the different components were important, particularly for coordination. So part of our training was really around kind of why you need to do the parent consent in order for early intervention to talk back to you. And I'm having another hiccup here. So that consent part. And then that bottom part was a really important part of our pilot. So you probably remember that I talked about that 2 in 5 kids that someone refers aren't able to be evaluated. So what we wanted to pilot in this project was how could early intervention let them know as soon as they weren't able to contact so that the provider could follow up and hopefully get that kid in. And so what we did is we leveraged this bottom of that form. So again, if the provider uses the early intervention referral form, they can hear back from early intervention. If they don't use the referral form, in some communities, they're not going to hear back. So one, getting them to use it and making sure that all the forms are filled out. But one of the great things that has been piloted through this effort is that now early intervention is faxing back to the practice when they can't contact the family. So that the provider can reach out and try to get that family in so we can reduce that 2 in 5 kids not evaluated. The second thing that we heard from providers is, can you give me a better pathway of when to refer to DBPs? There is a long wait list. I don't feel like 1 in the black is a good criteria. What is a better criteria? So we reached out to a number of developmental pediatricians. We reached out to the author of the Bright Futures recommendations. And basically what they said is the kids that they're consistently seeing still too late, so providers are holding them too long before they refer, are kiddos with intellectual disability and autism. And the way that you would see these kids in the developmental screening is that they will have delays in communication. But again, that's one of the most common delays. But they'll also start to have delays in problem solving or social emotional. So the enhanced decision tree that we gave providers about referring to DBPs was, again, that's 2 or more in the black, but it depends which domains are in the black. So if the 2 domains in the black are communication and personal, social, or problem solving, you should send them to DBPs. But if the 2 domains are like fine motor and gross motor, then it's okay to not necessarily send them to DBPs if they don't have any of these checkboxes, which again the providers have just found really helpful, because right now what they're doing is they're kind of holding that referral longer than they should because they know a lot of those kids shouldn't get to the DBPs, and so this has helped kind of refine for them which ones should. Another part of this project has been around kind of understanding what EI services that child is getting so you can identify supplemental services. So another part of this pilot is that rather than providing the full IFSP or the 9-page summary around what the evaluation findings are, starting this month, early intervention is going to be providing a 1-page summary to providers of what areas they were EI eligible, which may be different than the areas you identified in screening, and then what services they're getting. One of the things we heard is that they think some kids may be getting EI but not able to be getting enough to get some of the goals achieved that the medical provider would want. And you wouldn't be able to know what the EI is providing unless they tell you. So the whole point of this new form that's being piloted is EI's ability to tell you what services they're getting. And then we worked with the CCOs in the community to say, well, what do you cover on the medical side that could enhance follow-up for that child? So a summary for the providers on the medical side, in addition to some of the early intervention services, or if the child's not eligible for early intervention services, where are the places that you can refer that serve young children, 0 to 3, and what kinds of services would they be eligible for? So then the other 2 groups were really around that kind of 1 in the black or 2 in the gray. And again, the only difference between these 2 groups is that children should, in the group 2 or group B, they're referred to early intervention. And group C is really those kids that the provider, the parent's not concerned, and or the provider thinks that the child's really not at risk, but it's a lack of exposure. So again, rather than just doing nothing, there's no nothing pathway in the diagram. For both, they're going to do developmental promotion. And then for those kiddos that they're just convinced that they're not ready for an early intervention, rather than not doing any documented follow-up, then it's setting up a time to rescreen that child in 3 to 6 months in order to make sure that you're kind of identifying earlier than later some of those delays. And then the last pathway that we created was specific to one of the domains. So one of the things that we were a little bit concerned about is that the pathways to developmental PEDS and EI are good, but there's a specific group of kiddos that are being identified on the social emotional domain that the issue may be that they really need mental health services. So we created a pathway around those mental health services. So one, if they were identified on the social emotional domain, and then two, if they're having behavior or impulsivity with a significant functional impact and or exposure to ACEs, one, how they could consider putting early childhood mental health codes, and I put those on the right, which is a fantastic job of clarifying those. But then two, how would they then refer to mental health services? And here again, because of the differences between private and public and differences in the communities, we kind of created pathways around that. So that's the left side of the medical decision tree, which is kind of more those traditional referral pathways, developmental PEDS, EI. Mental health I don't think is a traditional pathway that exists now, so it's a new one. But the right side of the tree, that's where the early learning system services came in. So again, there may have been general awareness of these systems and definitely awareness of Cocoon Babies First for children with medical complexity. But what we wanted to fix was the kind of which services for which children and how do you refer to them. So the three priority resources that were identified in these communities were Cocoon Babies First. In these communities, they have centralized home visiting referral, so that's Family Link and Family Core. And then the third was these wonderful parenting classes that are run through OPIP that, again, most of the primary care practices had no idea about. So our goal was to say, for those kids that you identified at risk on that left side, any of those groups, these are three resources that you could refer to. But more importantly, these are some of the child and family factors that you need to consider in order to know which kids you should refer to. So again, the practices had kind of received general information about like what these services are, but to get to that kind of solid line, that standardized, consistent way of referring, what practices need is a medical decision tree of which kids, how do I refer, and to who. So again, what we did is we worked with the community-based providers, and this is again where it'll be community-specific, and identified what are the child factors that you're prioritizing in terms of kids that you can be able to serve with the limited resources that you have, and what are the family factors that you are prioritizing, so that we could train the providers. These are the factors that will make them more eligible for services potentially. And if you know about these factors as you're referring, it is really important to give that information, because the more factors there are, the more likely they're going to be to receive services. So that's the medical decision tree. The one thing I just kind of want to note is this was all brand new. OPIP created this through this project. So we created it, one, based on kind of looking at the data of where children fall out. We engaged experts in the field. But then secondly, we tailored it to the community. So I think the pathways are helpful for other communities because certain ones won't change. Developmental PEDS won't change. Early intervention won't change. But how children get to those pathways, particularly in terms of Babies First Cocoon, home visiting, whether they're centralized home visiting or not, the parenting classes, whether those exist in the community or not, mental health, how would you refer mental health? That's where I think the pathways, the 6 priority pathways are going to need to be fleshed out in each community, but kind of how those pathways are accessed and whether a community is building Help Me Grow or whether a community has centralized home visiting, that's where the nuance of the community level work and the nuance of the child and family factors that would make that child eligible are really important in terms of the medical decision tree. So the work we're doing funds us through June 17. So the reason I just want to note it is if you're interested in this medical decision tree, please let me know, and I can make sure to share it when it when it's done, because we're trying to kind of learn from the pilot, but also with that disclaimer that they would need to be customized for each of the community. And that's something that OPIP is now looking about. How do we get funding to kind of do this work in other communities, given that we see how rich it is? So the last thing I wanted to share about before I pass to Suzanne is I talked a lot about that families told us that, one, getting us to better services that are the best match for my child and family is going to be invaluable. But the things family told us also is that it's a very overwhelming experience to have your child identified in a clinic, be told these resources, and then go on your way. And these resources are often in very different places. And provider and parents, they really value their primary care providers. They really value their input. And these services that are trying to connect them are calling them. And, you know, there's some issues right now across all types of providers in trying to contact families when you're trying to call them. So what parents told us is make sure that the provider really talks through that referral, because it's going to make me think that that referral is more important. If you just send a referral and have that community agency that I know nothing about contact me, I may not answer the phone. The second is give me in paper something that helps guide me in the process. And then again, support me through it. Know that like I'm there that day, but I might have questions later on, and kind of support me in what my questions are going to be later on. So to address that need, what we did is we created an education sheet for parents that basically takes that medical decision tree and all those services that are on the medical decision tree and puts them on one page. And then the provider, when they're having that conversation about which services they're going to refer that kid, they check that service, and the parent is able to leave with what they can expect from that service in terms of how they're going to contact, who they could contact within that service, and then information about what that service is, so that if they want to do some research to make a decision about whether they agree or not, they have the right information. And then most importantly, this kind of, what do I do if I still have questions? How do I contact the practice? The second thing we did is, again, you know, it's just disturbing to see that 2 in 5 kids referred don't actually ever get evaluated. And there's some research that shows that parents make a decision in the first 48 hours about whether to go to the referral. And so what we wanted to do was kind of leverage off work in other states around how do you catch that parent in the time of decision. So what we created for the primary care practices was a script that they could follow up with families referred to kind of re-encourage them about the importance of the referral, and then be able to address any barriers. So for example, one barrier that's been identified is transportation. And the CCOs hadn't covered transportation to early intervention before because that wasn't a medical service that they bill. Through this project, because of the barriers identified, the CCO is now covering that service. So again, trying to meet people and support them in the process. Okay, so I've just told you kind of about the tools that were developed and the strategies developed, but I think it'd be most important to kind of hear from somebody on the front line, particularly for those of you guys that are in practices, about what it's been like to implement these tools. So Suzanne, I'm going to pass to you.
Excuse me. So I'm a pediatrician at Childhood Health Associates of Salem, and we're a practice that is comprised of 10 pediatricians, 4 physician assistants. We actually have 1 NP now, and we have 1 social worker, and we have 2 psychologists with doctorates who are working in our practice. We have 2 RN case coordinators, and we have 2 referral coordinators. We serve a population of somewhere between 15,000 to 16,000 kids. We use Allscripts as our EHR system, and probably most important, we serve a population of which 60% of the kids are served by Medicaid, 35% are on commercial insurance, and 6% are uninsured. Go on to the next slide. So we've been working with OPIP for the last 9 months or so on some quality improvement projects around early intervention referrals and developmental delays in kids in our practice. And so the first area of focus was just looking at our practice level data and looking at that to see where we needed to improve, and also sharing that data with our community partners so that we could look at the capability of the community to serve our patients. A second area of focus was working with OPIP to develop and implement the medical decision referral algorithm that Colleen has already talked about. And as you noticed, it incorporates ASQ, child and family risk factors, and goes beyond just the developmental evaluation and referral to EI, but includes the community-based resources. It also allowed us to become involved with Family Link and work on a pilot with them. A third area of focus, as Colleen was just speaking to, was refining the process for EI referrals and using the follow-up phone script. And what we found was that although our referral coordinators found that they just reached families maybe 50% of the time, EI noticed an uptick in parents calling them during that time period. So we feel like it was an effective intervention. And then we're also involved in this process for receiving communication back from EI and then getting that back to our providers. And lastly, we've been working on using the parent education sheet as providers. And we feel like it's useful in two areas. One is that it's a good tool for the provider when you're sitting in the exam room with the family and just being able to talk to them about the different options for services for their child in the community. Helps to remind us as providers, and I think it's a good visual for the parents about what options are available. And then I think the other value of the tool is that parent then can take that home with them, and it just refreshes their memory about what we talked about and gives them a little bit more information about the services that each of those organizations would provide. So those are the four areas on which we focused in the past year. Alrighty. So one of the areas on which we focused, as I said, was collecting data about our patient population and what we're doing with screening. And we've been screening probably for 5 or 6 years now. And what we found was that in a year period, we had screened 1,431 kids. And when we looked at those scores, the ASQ scores, we found that 28% of kids were defined at risk for delays. So that at risk, as Colleen has mentioned several times, is 1 score in the black and 2 scores in the gray. So that meant that out of the 1,400 plus kids that we screened, we should have referred probably around 400 to early intervention based on this 28% at-risk percentage. And what we found was that we had actually referred during that time period about 76 kids. And so that meant that probably 80% of kids were not being referred. So that was obviously very enlightening and humbling to us, but gave us some impetus to, to work harder on some areas. So this is an example, again, of the parent education sheet that we've been using as providers in the context of a visit with the family to help us decide with the family and in collaboration with the family what services they would like for their child, and then using this as a tool to go home with the family so that they can just kind of reflect on what we talked about and be able to get a little bit of a refresher on what that particular agency, what services they might provide for their child. Then again, we presented all this information to our providers in January, and we presented this this tool, this referral algorithm to our providers. And so we have been using that for the last couple of months, and we'll be looking at our numbers in the future to see how that's impacted our referral rates. But basically, we're attempting to refer kids who have 2 or more scores in the black to go ahead and refer them to early intervention, to consider a developmental PEDS referral, to think about what medical and therapy services might be appropriate for the child. And again, to do developmental promotion always. And then in group B and C, some of those kids will refer to early intervention. Some of them will observe for a little bit longer and give the family specific instructions about what areas they can be working on with their child over that time period. then I think this part of the algorithm is really helpful for providers because we certainly know about Cocoon. We didn't know about Family Link, and we didn't really know about all of the parenting resources that were available in the community. So this helps us remember about all of those resources that we can use to serve our kids. But I think just as important is listing for providers what risk factors for the family and child would guide us to refer to which agency, because that can be very confusing for providers and we don't always remember. So it's nice that the algorithm for our community has these listed in a really clear way so that it will help us to decide to which agency we should refer a kid based on whatever the family and the child's risk factors are. So I think as a result of this project with OPIP, we've learned many, many, many things. But I think an overarching theme was that the primary care providers have a lot to offer in terms of improving early learning efforts in our community. Pediatricians and family practice docs see kids probably up to 11 times in the first 3 years of life. And at each of those visits, we're doing either developmental surveillance or screening. And so we have a unique opportunity to follow these kids in these early years and develop relationships with parents and with and to get these kids to services early on in the community. I think we also learned that that collecting data is really important in terms of guiding our practice and helping us to understand that we need to do a better job of referral to EI and what all of our other options for referrals in our community are, but also to inform our community's discussion around capacity, because we've only been referring 76 kids and there were another 330 some kids that we could have referred during that time period. You know, is there the capacity in our community to serve those kids? So that was another learning that we had from this project. A third learning for us was just more concrete and really learning about the Parenting Education Collaborative, learning about the ASQ learning activity sheets, which are wonderful. If other practices don't know about them, there's something you can purchase, and there are sheets based on age and the domain of the delay. And they're in English and Spanish, and I think they're a wonderful tool. We also learned about the Family Link pilot, and we're lucky enough to be able to participate in that, and so that's been a wonderful thing. Excuse me. And we also didn't know that PCIT was available for privately insured kids in our community. So there were a lot of really concrete things that we learned that we could work on. And another thing that I think this project really brought into focus for us is that the engagement of the CCO in early learning is very different than what the engagement of primary care providers in the community can provide for children in regards to their early learning. I think the CCO can incentivize practices and others to do screening, but I think it's really at the provider level that the child gets directed to services that are really going to impact their learning in those early years. So I think the gist that I just want you to take away is that I think that there are lots of areas that we as primary care providers can help our early learning efforts in our communities.
Great. Thanks, Suzanne. I really appreciate it. So with that, we wanted to make sure that we opened up the community, the lines for questions. Again, we know that we kind of went for breadth and depth, and so if you have questions, please type them into the chat, because then Rebecca will send them to me and I'm happy to answer them, or send me an email and I'm happy to answer them if we don't get through all the questions in the limited time that we have. Just while you guys are getting ready for your questions, I do want to thank the funders for the work that I've been able to spotlight on the project. So this work is, the work that I just spotlighted is was supported through 2 different funding sources that's listed here. And then in terms of resources for you, we do have almost all these materials up on the OPIP website. So if you go to that link, you'll be able to see, I know some people noted some problems accessing materials. So if you have any problems, feel free to write me, but they also should be on the website itself. And again, this is my contact information. So what questions do folks have that we could answer today before we sign off, for either Suzanne or myself?
Thank you, Colleen. As you mentioned, there was a handout that wasn't working from the webinar, so we'll make sure to link or post that on our website with the recording. Yes, this webinar is being recorded. And Colleen, I sent you one question. Yeah. Do you want me to read that, or do you want to just read that? And then there's one more question in the pane.
Oh, okay. So one of the questions was, did we discuss the capacity of the services to be able to provide that service for more and more children? So, you know, we did. Part of the reason we started off the conversation around screening rates and kind of making sure that we got the practice level data around 20 to 28% of children was so that we could actually say, because I think at the beginning the referral pathways were saying, yeah, refer those kids to us. And then some of that refinement in the decision tree of whether they need to be privately or publicly insured, what kinds of risk factors, you know, why do more risk factors matter, was informed from the capacity conversation of when we played out for them, like Suzanne just noted, that over 400 kids were identified at risk in her practice alone, one practice in Marion County. The total referral rate to early intervention in that county was 500 something. So, you know, we really wanted to be sure as we were going to implement this, these are the numbers. And so for some of that refined the pathway of which kids we put into the hopper. That being said, this community said, let's really refer them in, because we can't have a conversation about the need for services if we don't demonstrate the need for services. So that's partially why I say this is version 1.0, because one of the things we're doing is we're going to be tracking how many kids should have been referred, how many got referred, and then how many were able to be served by those programs, so that we can have some better quantitative data at the community level about how many kids need it versus how many kids with the current funding are able to be provided. So as you can imagine, you know, with the current budget discussions around Babies First, for example, we're keeping that pathway now. If that program, you know, loses funding, you know, one of the things that's been helpful is to give that program information about the number of children that should be getting that service that we're identifying. But then also, you know, we're going to have to refine that pathway based on what community services exist, which is why I would love for this template to be one time, but I think, again, it needs to be tailored to the community, and it needs to be tailored to the community resources.
Perfect, thank you. And sure, and actually, while right before that, for folks who do have to jump off, I just want to thank you so much for tuning in this morning, and I want to give a huge round of applause and thank you to Colleen Ruland and Dr. Suzanne Dinsmore. And just wanted to let you know that you're getting lots of praise for the well-deserved praise for a lot of this work in the chat. So rather than questions, we've been getting a lot of praise. But there was a question about how did you engage the pediatrician in the clinic, and then another question about, do you think that the state should look at percentage of referral as a metric? We now do developmental screening percentages. Yeah. 2 awesome questions. So I'll start with the second one first. I mean, I'm so thrilled that we had the developmental screening metrics that we did, because I think they forced a focus on this screening area. I've been working on developmental screening here for over a decade, and the reason I developed the developmental screening measure used by the CCOs is because what's measured on is what's focused. So we've had these huge gains where I think we are, particularly in a state
if we haven't invested in early learning hubs, I think there may be some debate about whether we should go there. But because we have also we've invested in CCOs and developmental screening, but we've also invested at a state level in early learning hubs and this idea of an early learning screening, childcare screening. And I do think we are now ready to have a measure that's more about follow-up to developmental screening. And in particular, I think there's better opportunities around that. So, for example, I'm on the metrics committee, the measuring success committee that looks at measures for early learning hubs, and I'm pretty strongly trying to ask for consideration of measures that would look at what do the early learning hubs do to help incentivize follow-up to developmental screening, because for me that feels like the more important lever. So I think as much as we all can advocate for that, I think that is a great next step. In terms of the primary care practices, I'll share my perspective, but then I'll let Suzanne share. The way we reached out to practices was, one, we're not asking you to do something more. So the scope for this project was this is practices already doing screening. I do think there's a whole other set of work for the practices not. And Marion and Polk, 86% of practices are still not doing screening. So we are focusing on those doing screening. So one of the hooks we had was, we're not asking you to do more. We're not asking you to implement a new tool. What we're doing is we're helping you do better follow-up for those kids you are screening. Providers don't like to be doing something that they don't know what they're going to do the follow-up for. And particularly, I think the practices, this hit on a number of parts that were frustrating to them. I think it's been frustrating to them, and they may not have understood their role in it. The communication gap with early intervention, it's frustrating for them when 70% of their referrals in these communities don't result to early intervention, don't result in services. And so this has kind of helped them understand better why that happens. And then 3, they want the best for their parents and their children and their parents. And so it's kind of connected community resource and given them very concrete tools. And then OPIP has just provided them facilitation support. This is important implementation work. And so I think one of the hooks for them was this kind of hands-on at the ground level support that not only was with the practice, but was with the community-based providers about, like, how do we make sure that there's coordination and communication. Suzanne, is there anything else you would add about, like, how do you engage other primary care providers in your practice?
I think there are 2 things I'd like to talk about. One is just how OPIP engaged our practice and asked for us to have a practice-wide team that met with them on a regular basis, and their facilitation of those efforts, reminding us what we were supposed to be working on, and just kind of keeping us on track, I think was really helpful. And so we had other providers on that team, IT, the case managers, and some people in nursing also. So I think that was really helpful in terms of making changes in the practice, practice-wide. And then we had a presentation for the providers in January that went over the data and kind of showed us our practice data and why we might want to think about some changes. And then also gave the providers tools that were really specific and helpful about services that that are available in the community to help these kids. And I think that is super helpful also. And so those are the 2 ways in which we've been able to help other providers in our practice understand these issues better.
Perfect.
Great.
Thank you. Yeah, thank you. We are 5 minutes over the hour, and I know folks will have to start jumping off. Colleen, what is your preference? Should we follow up to the last few questions via email or?
I am, sorry, I'm just trying to, I lost them. I can follow up over email, particularly Ken, I can follow up with you around the data part. But let me just answer 2 of them from Pat. So one of the comments was that, there's kind of two important issues that were raised in this project. One is that, so we have a huge push on developmental screening in our state. And the hard part is that, so while we are one of the highest states in the country around developmental screening, and I know that because I've looked at national survey data, but I also, because I'm the steward for the developmental screening measure, I see state level data that's reported to CMS that isn't publicly reported yet. So what's fantastic is if you think about, like, kind of on the left-hand side, we are increasing that screening rate. The trick is that we also, though, have a state in which, by virtue of how we fund our early intervention program, we have one of the most strictest eligibility criteria across the country. So ironically, while we're the highest on developmental screening, and while most children are screened in our state right now using the Ages and Stages questionnaire, those kids identified at risk, that's not the criteria that'll make them eligible for EI in our state, given how we currently fund early intervention in our state. So there's this kind of eligibility conversation of, we are identifying more kids, and there's a significant group of those kids that we're identifying that are not going to be able to be eligible for services in EI. The second issue is that given how we fund EI, we also have an issue in our state that not all children that are getting EI are getting the robust set of services that are recommended, because EI doesn't necessarily get funding to provide that robust level of services. And that is why, Pam, that's why we wanted to implement that one-page service summary, because we wanted, what I think practices didn't know is they weren't doing secondary referral of additional services that would help supplement and support that child, because there was this conception like, well, if they're getting EI, then they're getting a robust level of services for all the things I identified as at risk. And so what's been fantastic about our partners with the Willamette Education Service District is this momentum to pilot a summary that could give that provider what they were eligible on and what services that they were getting, so that they could see that, you know, it was once a month OTPT, not once a week. And that was why we wanted, for the publicly insured kiddos, to kind of summarize additional services on the medical side that could more robustly address that kiddo. But again, people weren't addressing the secondary follow-up steps because they didn't have the information to do that. The one big barrier about capacity that has been identified is that those services are services covered under for publicly insured kids. So in these practices, you know, they're screening all kids, not publicly insured kids. And so one of the barriers practices have already noted is the privately insured kids whose insurance doesn't cover all these services and whose families can't pay the $1,000 deductible that it would take to go to OTPT. There's just a gap that we've identified these kids, we've identified these delays, but we don't have enough services to address their delays. So we may not be getting to our goal of school readiness just yet. And then Ken, I will follow up with you on the measurement part. I would love to have a conversation with you on the measurement part. And then Nora, you had a question about the potential incentive measures. Are you talking about the possibility for that for the CCOs or the learning hubs? So for the metrics and scoring CCOs, and kindergarten readiness is a global measure, not the kindergarten assessment that's done in school, but potentially elements from that, has been talked about a potential future measure that may potentially be considered for metrics and scoring. So there may be potentially in the next 5 years, or I don't know what the timeline would be, consideration of a metric around that. And there's a number of us that are talking about what that metric would look like. How would you operationalize it? What codes would you need? What modifiers would you need? But then secondly, there's a set of metrics that the early learning hubs have to report on. And so the current metrics are out, but right now the Measuring Success Committee is considering measures for the early learning hubs that would be in the next round. And so it's, to answer your question, it's both. It's thinking about how could you enhance the measurement within the CCO part, and then, or modify, you know, switch in or out, and then two within the early learning hub part.
Perfect. Thank you so much, Colleen, and thank you again, Dr. Suzanne Dinsmore. Thank you, everyone who has tuned in. Obviously, it's a very large topic, and you guys have put in a lot of work to help develop these pathways, referral pathways, and we could probably be here all day talking about it. But for those who still have questions, we will make sure to follow up via email, and then there will link to resources on the OPIP website from our website, and we'll have the recording for the webinar. Please do, if you get a chance after the webinar, to fill out the post-webinar survey that lets us know how we're doing and how we can improve. But that being said, I will turn you guys back to the rest of your day, and thank you again so much for joining us.
Thank you.
All right, thank you. Bye.